So to put it into perspective, if you've got relapsing remitting MS, the rate of impairment is about 40%. So there's 60% who don't have it. If you've got secondary progressive MS, the rate goes up to 60 to 70%, but there's still going to be 30% who don't have cognitive impairment. And then the challenge is, well, how do you treat them? And we know that medication is not particularly helpful. I mean, the medication data thus far don't give enormous cause for optimism. However, cognitive retraining is now emerging as potentially quite helpful. So there's evidence to suggest that through various cognitive paradigms, retraining paradigms, people could improve their memory, perhaps even their processing speed, or even some aspects of executive functioning, their decision making. The challenge, however, with cognitive retraining is that it's very labor intensive. Not many centers do it. And so there's the logistics of getting that kind of treatment to large numbers of patients. Yeah, very much. So I mean, cognitive retraining is not lumosity. I think lumosity is good in keeping people active. You know, you want someone to be active. You want someone to be physically active, but also intellectually or cognitively active. So I think that's where programs like lumosity probably have an advantage. But that's not going to improve your cognition. That's not going to bring about an improvement in your memory or your processing speed. There, you have to have a program that's absolutely tailored to the deficit that you've got, and then in a graduated fashion you build up, going from module to module to module. Well, it's very hard. I mean, I think that's really an excellent question. People with MS have often lost a lot already. You know, they come to see you, they're not walking as well, or their vision might be a bit impaired, so they're very conscious of their loss. To then tell them that in addition to what you've lost, you've now lost some of your intellect, can be very painful for people, and you have to break the news very carefully. At the same time, you also want to hold out some promise of help. And potentially, I'll say this potentially because you have to have access to these programs, you might be able to get help to them. But it's still very early days in this. I mean, you know, superficially the overlap is that we're dealing with cognition. But I'm very careful not to go the Alzheimer route or not even make mention of Alzheimer, because in many ways it's people's worst fear. If you tell them, well, look, you've got cognitive impairment, many people think, oh, this is Alzheimer's, it's going to get worse and worse, there's nothing you can be done, and I'm going to end up, you know, dying from dementia. And it's not the case in MS. You know, the long-term outcome is very different. There can be significant cognitive decline over time, there's no doubt about that. So 10-year studies have shown that cognition can deteriorate appreciably, but it's not this inevitability to it. And that degree of decline, you know, to profound dementia, you don't see as the norm in people with MS. Yes, the impairments can be disabling, but not to the same degree as with Alzheimer's, and certainly the cognition is not going to kill them the way it does with Alzheimer's. The drug therapies that provide some help in Alzheimer's don't work in MS. So donepezil, for example, which is, you know, standard drug therapy for someone with Alzheimer's disease, is not effective in helping cognitive impairment in people with MS. You know, the data suggests we cannot borrow from their medications. Cognitive retraining, possibly, but once again, you know, these are different pathologies. You know, Alzheimer's is this inexorable decline, progression, etc. MS is not necessarily like that. I think the brain is going to be more plastic in people with MS, so potentially they can benefit far more from cognitive retraining. So it's a more optimistic message for them by far. We're still developing the distractor tests for cognition. I mean, we've just started on that journey. And we've just published our first couple papers this year. So that's going to be a new avenue for us, and I can see us staying with us for a good few years as we refine our distractors, make our distractors more sensitive, build them into tests. So that's going to absorb a fair amount of time. And the other issue that we're looking at with brain imaging, which I think is intriguing, is how does cannabis affect the MS brain, and what are the brain changes linked to cannabis use in people with MS, and what is their association with cognitive impairment. And that's also going to be a long-term project.